Hi guys, this is John Adamson, the Rehab Documentation Guru, and this is a video related to a question that Adam Alstein or Alstein, forgive me Adam if I'm misstating your name, but I wanted to respond to a question he posed. It's been about 2 or 3 weeks now ago, and forgive me for being a little bit quiet because it's late at night here in the Ukraine where we're at for one of our adoption trips. And my family is trying to get to sleep that's here with me. So anyway, I wanted to address his question, which was basically this. How do you treat a patient with severe dementia in the subacute phase or post-acute phase of care when they have a medical condition, but really it's the dementia that's limiting them in functionality? And Adam, let me know if I got that question incorrect. I'm going off memory, which can always be a bad thing. But yeah, but this is a common question that PTs have, and it's actually one that I used to ask myself quite a bit back in the day when I was a treating therapist, and I hadn't really been well educated in dementia, hadn't thought through the implications of my scope of practice. And so I wanted to address this in brief, and I'm going to relate it to things that I teach in my course on documentation. Many of my subscribers have been to that course and will understand the verbiage I'm using, but I'm going to try to make it clear, hopefully for everybody that's watching this video, whether or not you've attended my course on documentation. So first and foremost, when you have a patient that's referred to physical therapy, the thing that we're going to look at is, do they have a functional decline in an area of functionality that PTs address? And so we're going to look at mainly the functions of mobility. Do they have a mobility deficit? Because that's the primary area we work on. If you look at the APTA's definition of what physical therapists work on, it's mainly related to mobility. We do have some non-mobility areas that we work on. For example, we work on wounds. So we'll address wound care. But with mobility, we can certainly see a patient with dementia have mobility concerns. Now, once we've identified the functional deficit, now we're going to look at underlying impairments and how they relate to our scope of practice. Now, as a PT, we learn to measure things like strength, balance, coordination, proprioception, kinesthetic awareness, things like that, things that we can address as physical therapists, either by improving that underlying impairment like strength, balance, coordination, making that better. That's one aspect that we can treat for. The other is to teach the patient how to compensate for those deficits. So if they're not balancing well and they don't have much strength, we can teach them to use adaptive equipment or other DME to now do the function, overcoming the underlying impairment that's not improving. So that's another option that we do have. But for patients with cognitive dysfunction, it could be that they cannot learn compensations. And that's where knowing where they are cognitively is really important. The big thing to note is that patients in late stage dementia do not have the capability of learning new activities. And even mid stage, you're going to have to keep your things that you're training a patient to do for compensations pretty simple. So that it might be too complex for some patients to learn a compensation. And then finally is environmental adaptation, which is the final component of care planning, and looking at whether or not there's something in their environment we can change. Like if they're not balancing well, it could be that there are environmental factors that are causing deficits in balance. Like, for example, high pile carpeting, not much contrast in colors between thresholds, glare from excessive lighting. Like right now, I'm in an environment where there's glare from the light above me. And so all of these factors in the environment can play into somebody's deficits in balance. So we can change things about the environment. And of course, one aspect of environmental adaptation is caregiver training. So first we look at that. Are there underlying impairments that fall within the scope of practice of a PT to address? And if there are not, so let's say the patient is balancing fine, if they are strong, if they've got adequate range, if their sensation is good, if they've got no vestibular problems, And then all we've got is the dementia, which is causing behavioral changes that are preventing them from walking or moving around safely. At that point, a physical therapist has to question whether or not it's really within their scope of practice to treat them. And one thing I would say about that is this. While there might be no impairments that we in our scope can improve or teach them to compensate for, even if it's just only the cognitive aspects that's causing them to have problems with mobility that a PT would be concerned about, then I could still address the environment, lighting, barriers. People with dementia, one of the things they have is centralization of their focus. So somebody that's not demented is aware of not only what's in their visual surroundings, but things like if they're coming around a corner, they know that there could be somebody coming the other way, so they use certain techniques to avoid hitting somebody coming around the corner. Somebody that progresses towards dementia, especially once you get to mid-stage, you've got really tunnel vision focus, and then late stage you become more internally focused and not really aware of the external. Those patients are going to have a hard time with low items like a chair or table that's low and outside of their immediate visual field, going to be presenting easy tripping barriers. And so those are environmental factors that we can address as PTs. But the big thing we got to consider with environmental adaptations is that that'll be very limited frequency, intensity, and duration, because once we identify those things, we can address them very quickly. Even caregiver training, general expectation for caregiver training is going to be about 1 to 3 or 1 to 4 visits, and then you're done. So to your question, Adam, the biggest thing we've got to look at is, are there other underlying impairments that I can impact? And if cognition is the only thing that's the problem limiting functionality, then I'm probably looking at a very brief care plan and very limited involvement of PT. Hope you found that helpful. This has been John Adamson, the Rehab Documentation Guru. I appreciate your comments and suggestions. Please like and subscribe. And as always, make sure you get paid for what you do. This is John Adamson from the Ukraine, signing off. Bye-bye.